Okay, so now we start Learning Plan 5, which is Managing Care for Patients Experiencing Thought Disorders. And we are looking first off at Chapter 12, which is Schizophrenia Spectrum Disorders. So the clinical picture is that schizophrenia affects about 1% of adults, and it's characterized by psychosis. So what psychosis means really is that it's like a break from reality. So they don't perceive reality the same way that people around them do. So they have altered cognition, which means their thought processes are impaired, perception, which could include hallucinations, and reality testing. So sometimes they truly don't know the difference between what is real and what is not real. 75% of cases of people that have schizophrenia develop gradually, and usually the age of onset is usually late teens to early 20s. So here in the book they're saying 15 to 25 years of age. So teenage to early 20s is very typical for the time of onset, which if you think about could make it a little bit difficult for diagnosis, because that's also a period in a person's life when life in general can be very tumultuous and there's a lot of experimentation, and kids in that age range don't necessarily always make good decisions. And so it's actually, adolescence has sometimes been called a period of normal psychosis. So sometimes it might be hard to figure out that something is actually going on with your young person just because of all the changes and all those developmental difficulties that are happening at that age. Child onset and a late, like older adult onset do happen, but they are much more rare. So the highlights of the criteria for schizophrenia: 2 or more of the following symptoms for a significant period of time in 1 month. So having delusions. So a delusion is a false fixed belief. You cannot talk them out of it. It's not based in reality, but they think it is real. And you cannot, no matter how hard you try, you cannot talk them out of it. So it's a false belief that they have. And hallucinations then are a bit different, and sometimes people confuse these, but really they're quite distinctly different. So a delusion is an idea or a thought. A hallucination is an actual sensory experience. So again, based on something that is not real. Disorganized speech. So sometimes they have speech patterns which makes it very difficult to communicate with them, very difficult to understand what they're talking about or how they feel. And it even makes it very difficult to diagnose medical problems because they're really not able to clearly articulate how they feel physically, their signs and symptoms. They may be grossly disorganized or catatonic in their behavior, so their behavior may not be purposeful. Or catatonic, it may just be that they are completely inert. They don't respond to you. They keep their eyes closed. They stay in the same position for hours. They don't eat. They don't go to the bathroom. So that's true catatonia. They may have negative symptoms, which are diminished emotional expression, almost like depressive type symptoms, or avolition, which means basically no get up and go. So they don't have any motivation to do things. Usually we're thinking about like just your normal activities of daily living, like getting up out of bed, making themselves something to eat, getting in the shower, brushing their teeth. Matter of fact, many times those negative symptoms can be so pronounced that the person could be a young person in their 20s or 30s or early 40s, and they have lost all of their teeth. And mostly that reason would be because they don't brush their teeth. They don't take care of themselves. They don't take care of their ADLs. And sometimes their teeth rot and they actually have to have them all extracted. So that is definitely something that we see very commonly in people that have schizophrenia. They do have a functional impairment of some kind, so they have difficulties functioning in their day-to-day life. They may or may not be able to, again, there's a spectrum. So some people are more highly functional than others. Some people with schizophrenia get married, have children, hold down a job, all those types of things, and function, pretty okay, maybe less than somebody else, but still considering their illness, pretty okay. And some people can't function at all. They can't maintain an apartment. They can't work. They barely can take care of themselves. And most of the time their hygiene is really poor. Again, their teeth are falling out and they're not able to get adequate nutrition, exercise, just any of our just normal habits of daily living. So definitely some kind of functional impairment. They're not functioning as highly as they did before they got the illness. And you have to have a continuous disturbance of these symptoms for at least a 6-month period. Otherwise, you might be looking at something else. Is there something else organic going on? Could it be drug related? Is it another type of illness rather than schizophrenia? So, case study, Eric M., 18, has always been a good student. However, in his second semester of college, he begins for the first time in his life to have trouble concentrating. So that's a very typical scenario. When his family doesn't hear from Eric, they contact the school only to discover that his roommate says Eric is talking weird. Asked what he means, the roommate says, well, he says stuff that doesn't connect, doesn't make any sense. I asked him if he was high or something, but he said no, and I believed him. On further investigation, Eric's professors say he's been missing class after starting out so well. So that's actually a very typical scenario. So we haven't really talked about causes of schizophrenia yet, but going off to college can be a very big stressor for somebody who's, in that young, or older adolescent, I guess, time frame, like, again, late teens, early 20s, the first time being independent. It could be just very stressful being away from home for the first time, having to manage an adult all by yourself type of thing. And so sometimes that stress, along with that genetic predisposition, can bring it on. So actually this college scenario comes from the book, but honestly, I have known people that have developed schizophrenia and it has been first noticed when they're away at college for the first time. So Eric's roommate says his speech doesn't connect, it doesn't make any sense. He sort of gets derailed. Which of the following symptoms is Eric displaying? So, we haven't really talked too much about this yet, but avolitional speech, delusional speech, well, we don't really know what the content of his thoughts are. The disorganized speech or diminished emotional expression. Well, we don't have enough information, I don't think, for any of the other ones except for disorganized speech. So C would be the correct answer. So that is a main category of symptom, having disorganized speech, not really able to make sense of what their communication is. So now epidemiology, so childhood onset schizophrenia, only 1 in 40,000 children, so it really isn't very common at all. No difference related to race, social status, and culture, so it cuts across all socioeconomic groups, race, culture. You can be rich, poor, from any area of the world and have schizophrenia. It's more frequently diagnosed in males and for some reason in urban areas. Lots and lots and lots of comorbidities. Some comorbidities that aren't on here, I'll add a few to this list, but we'll start with what's on here. Definitely substance abuse disorders. Nicotine is huge. I remember when I was first working as a nurse in the 80s, patients would come in with schizophrenia and they would bring their own tobacco with them. And, I don't know why we did this, but we trusted them, I guess, that it was just tobacco. They'd bring their tobacco and their rolling papers, and we allowed them to smoke on the unit, or sometimes we would bring them outside if they were safe and let them smoke outside. But I absolutely have this memory of people with schizophrenia bringing in their tin of tobacco and rolling their own and smoking without even a filter. So they wouldn't even smoke, most of them wouldn't even smoke regular cigarettes. So in order to get more nicotine, they would not even use a filter. So that is absolutely huge. Smoking, for some reason, I read an article a long time ago about how smoking actually kind of helps their cognitive function. It kind of makes them more focused and concentrate a little bit better. However, of course, smoking is not a healthy lifestyle habit, so it's not like we should be encouraging people to smoke. But I do think that it's interesting that they've made some correlation between why people with schizophrenia smoke so much. So nicotine dependence is huge, and along with that, many times people will also drink a lot of caffeine. So nicotine and caffeine kind of goes hand in hand sometimes. You know, you light up a cigarette while you're drinking your coffee, that type of thing, drinking lots of colas. So if you watch the video, which I hope you will, on Heather under Learning Plan 5, it's interesting to watch some of her behaviors in there. She is smoking towards the end. Not sure. It looks like it might be a roll-your-own kind of cigarette. I'm not positive. I'd have to look back. But in the very beginning, notice that she has a cup of coffee in one hand, and then at one point a cup of soda or a bottle of soda, whatever it is, in the other hand. So it's like she's got double-fisted caffeine. So those two things are definite comorbidities. And of course, caffeine, you know, we might think, well, a cup or two of coffee is fine, but it usually is excessive caffeine intake, which really isn't good for anybody, whether you have schizophrenia or not. Other comorbidities for sure are anxiety, depression, and suicide. People with schizophrenia really, truly are a huge risk for suicide. Sometimes it's because of their hallucinations. They may hear a voice, and that voice tells them really derogatory things about themselves and tells them maybe to commit suicide, to jump off a building, to crash their car, whatever. And if they have command hallucinations especially, they usually end up following whatever the command hallucination tells them to do. So if the command hallucination is saying kill yourself, they may end up committing suicide because of hearing that voice. They definitely have depression. So some of the neurotransmitters that work in depression also are similarly dysfunctional in schizophrenia. And anxiety also is huge. And again, anxiety, depression goes hand in hand. I think we talked about that in the other learning plans. And so also with schizophrenia, many times people have just terrible levels of anxiety. Therefore, based on the anxiety, depression, and suicidality, in addition to the nicotine dependence and caffeine, they do use other substances, illegal drugs and alcohol in order to try to make themselves feel better. So substance abuse in general is for sure a comorbidity, not just the nicotine and caffeine, but any type of illegal drug. And also people drink sometimes because they think that drugs or alcohol is going to calm them down. It's self-medicating, basically. They want to drown out the voices or get rid of the voices. So they think by using drugs or alcohol that that's going to get better, when usually it doesn't. Usually it makes it worse. So we do have to look at all these different types of comorbidities with schizophrenia. They may have physical health or illness problems. They may have those problems already, not part of their schizophrenia. And if they have any other physical illnesses, having schizophrenia is going to make it that much harder for them to take care of their own health. They are not going to be able to take care of their physical health. Think about how difficult it is for a person who doesn't have schizophrenia maybe to manage their own diabetes or to manage their heart disease or any number of different types of chronic health conditions. So they really have limited resources, intellectual, social, and money resources sometimes to really take care of their own health very, very well. So having a physical illness is absolutely a comorbidity. So they may have an illness ahead of time. Now they're unable to really take care of it the way they used to. Or there's actually a couple of illnesses. One I can think of directly relates to the use of psychiatric medication. So sometimes people develop tardive dyskinesia. And again, there's a video on tardive dyskinesia from YouTube. And you should really watch at least most of that just to see how bad tardive dyskinesia can get and how difficult it makes a person's life. But also diabetes. So people aren't getting tardive dyskinesia as much from the newer classes of psychiatric antipsychotic medications, but now they're getting diabetes. So weight gain is a huge problem with some of the antipsychotics, and then people are developing diabetes as a result of that. So now, again, you have a psychotic disorder. Sometimes you're with reality and sometimes you're less with reality, and now you have an illness like diabetes to manage. So it really makes it very, very difficult having these comorbidities. Polydipsia is actually something that is a comorbidity, and it can be kind of like its own separate symptom of schizophrenia. And I've actually seen several people with this. A few years ago, they started turning off the water fountains on 1K, just turning them off completely, because people with polydipsia would be drinking out of the water fountains excessively. They would sometimes have to lock their bathrooms because they might drink out of the toilet or drink out of their faucet in their bathroom. So they had to shut off the water fountains, or bubblers as you guys call them in Wisconsin, shut those off in the hallway and just kind of make extra water inaccessible to patients because they will get water intoxication. And it is sometimes just a symptom of schizophrenia. It really is kind of interesting, and I have seen patients that have this. There have been times in clinical where I've had to encourage a student maybe to keep track of somebody's I&O because it was kind of suspicious. We were wondering and needed to gather more data if that person truly was developing polydipsia. And then, of course, along with the polydipsia, if you're drinking excessively, usually you're also urinating excessively. So keeping track of somebody's I&O if you suspect that they are, overdoing it with the water. And usually, again, it is plain water. They're not asking for juice. They're not asking for milk and other fluids that have electrolytes. They're drinking kind of plain water. So just something to think about. So some biologic factors. So genetics. It is definitely an inherited disorder. So about 80% of the risk of schizophrenia comes from genetic factors. So it definitely runs in families. I have a friend who, she is one of 5, she's the middle child actually of 5 children. So there were 5 siblings, and her oldest brother and youngest sister both developed schizophrenia. And then in talking to her, it sounded like there were many aunts and uncles, kind of, I think especially on her mom's side of the family, that also had schizophrenia. So there were multiple family members. My friend's parents did not have schizophrenia, but again, they had 5 children, and 2 out of those 5 developed schizophrenia. So it is definitely an inherited disorder. And of course, the brain is a very complex organ, and there's lots of neurobiological theories and other different types of chemicals involved. Dopamine is kind of the main one that we think about. And it's interesting because when I used to take care of patients that had Parkinson's disease, L-Dopa is the main medication used to treat that disease. But if their dosage became too high, that person would become psychotic. So it is interesting just to think about the role of dopamine in the brain and on our moods and in our ability to perceive reality correctly, so that if a person's dopamine level gets too high, they become psychotic. So it is definitely a reason why the medications that we choose to treat schizophrenia lower the dopamine levels. So then that person, we would hope the target symptoms of hallucinations, delusions, and all the other types of disorganized speech, the psychotic symptoms, we would want those to be reduced. You don't need to memorize all the different complex neurochemistry, but just to be able to relate that the medications do target the different neurotransmitters that we think are involved with schizophrenia. There can be brain structure abnormalities also that are in the brain. So you can use an MRI, I think PET scans, to kind of look at the brain. And in the brain of people with schizophrenia, sometimes there are reduced volume, changes in the hippocampus, all different, again, types of brain changes. So you don't really need to memorize the different structural brain changes, but actually just to realize that it is a brain disorder. There are structural changes in the brain of somebody that has schizophrenia. There are definitely psychological and environmental factors. So prenatal stressors are something that can actually bring on schizophrenia. So it's been shown that infection during pregnancy increases the risk of mental illness in the child. So that is really something that's very, very interesting, and I think more research is being done on that. But those infections, even if the child isn't born yet, the infection of the mother actually increases the risk of that child developing schizophrenia. So just something kind of interesting to think about. Lots of different types of psychological stressors can precipitate, but usually when we think about different types of stressors, whether prenatal, psychological, environmental stressors, things like that, those in and of themselves don't cause a person to develop schizophrenia. However, if they do have that genetic predisposition, it can be the thing to kind of tip them over the edge and start the symptoms to occur. But it's not that in and of itself, if you're under a great deal of stress, you're going to develop schizophrenia. That's really pretty unlikely. Your book does a really nice job of going through and talking about psychological stressors, and especially childhood stress and childhood abuse, and just how children, when they're subjected to constant abuse, actually can develop some changes in their brain, and they are going to be definitely increased at risk for schizophrenia. So, and throw into that poverty and all different types of other environmental stressors. Living in urban areas, crowded places can sometimes cause, different types of chemical reactions in the brain and actually structural brain changes. As far as prognosis, it really is kind of variable. Some people with schizophrenia, again, are able to get married, have children, have a job, maintain their own home or apartment, and live a pretty decent life as long as their symptoms are under control. Some people don't respond as well to medications, and their symptoms may never be under very good control, and they may end up either being institutionalized or perhaps living in a group home. Some people become homeless and just really unable to care for themselves. So it really is quite variable. Kind of depends maybe sometimes on how young they were when they received their diagnosis, and other types of support systems and treatment, things like that. So when they're first treated. But there are people that that pretty much mostly everyone that has schizophrenia has it for the duration. I've only heard of very few rare instances where somebody had schizophrenia when they were younger, and then they somehow, all of a sudden, now they don't have schizophrenia anymore. I'm just wondering if perhaps that person, the few people that I've talked to that swear that their family members used to have schizophrenia, but they recovered, not really sure that that's accurate. Perhaps schizophrenia really wasn't the accurate diagnosis for them. It's pretty much of a lifelong chronic condition. It can definitely be managed, but again, it's so individual because there is that continuum of symptoms, and some people have very serious symptoms. Some people have less serious symptoms that are more easily controlled by medication. Some people don't respond to medications very much at all, so that would make it very difficult for them to live productive lives. Back to the case study. Eric's parents arrive on campus and he agrees to meet with them and a campus counselor. He appears anxious. He expresses sorrow that his grades are suffering, acknowledging that his concentration just isn't there. He says he feels something weird is happening to me and describes frequent distressing thoughts. He admits to feeling suspicious of everyone he passes. Eric's parents and the counselor both notice what the roommate had described about Eric's speech. He agrees to see a psychiatrist, and an initial assessment and history indicate he has only been experiencing some mild changes in his thinking and mood for about a month, ever since returning from the winter holiday. The examiner confirms that his speech is sometimes disorganized, and his ability to concentrate and study is diminished from his previous long standing as a strong student. So the assessment now. So we're going to be thinking about what assessments do we make when somebody is first being diagnosed with schizophrenia. So we have to think about the prodromal phase and then the general assessment of positive symptoms, negative, cognitive, and affective. So we will take a look at all of those. In general, the prodromal phase is the phase where symptoms are just starting, but you're not quite sure what it is. So think about you yourself, if you're coming down with something. Say you're coming down with a cold. Before you first start the sneezing and coughing and itchy throat, runny nose, whatever those, the main symptoms are, you just maybe don't feel quite right for a day or two. You just feel a little bit more tired than usual, a little bit more dragged out, but you're not really sick. You can't put your finger on it yet. That's kind of what the prodromal phase is like. There's no really outstanding symptoms, but you just don't quite feel right. There's a really interesting box on page 197 in your book that talks about, can schizophrenia be prevented? So it really is kind of interesting, so that if you are in that prodromal phase and you're not feeling quite right and you're thinking something is maybe a little bit off, but not so, you're not quite sure what it is and they're not quite diagnosing you yet, it looks like there are things that there's a box called, can schizophrenia be prevented? So very interesting to think about maybe taking some measures to try to, the book talks about like decreasing stress level, and if the person is using illegal substances, to stop doing that, because sometimes illegal substances can trigger the onset of schizophrenia. So an example, I do remember a patient once saying that he went to this party and there were all kinds of drugs there, and he just took handfuls of everything that was available. He doesn't even know what he took. And after that, he had developed schizophrenia. So it seemed to be a direct result of an assault to his brain from all these different illegal substances. So reducing stress, and it looks like maybe they're doing some studies on the use of omega-3 and omega-6. So very interesting just to think about, can we prevent it? So the phases of schizophrenia. Again, the prodromal is the onset. Some mild changes, but you can't quite put your finger on anything. The acute phase is when you have an exacerbation of the symptoms, and the acute phase is what we usually call like their first psychotic break. So they actually have symptoms that are consistent with schizophrenia. They have psychosis, they have delusions and or hallucinations. Their thought processes are disorganized. They can't concentrate. They may not be able to get themselves in the shower, brush their teeth. Again, all those, we'll talk about what the positive and negative symptoms are. But you have just that acute exacerbation of symptoms. There they are. You can't deny what it is at this point when you're in that acute phase. Because that person has taken a break from reality in that acute phase, the first goal would be for patient safety. Safety of themselves, safety of everybody else around them. They may be a risk to themselves or others. So usually they're going to need to be in the hospital for stabilization of their symptoms. So safety issues are huge. We really do need to look at patients as far as their thought processes. Do they have suicidal or homicidal thoughts of self-mutilation? There are some people with schizophrenia that want to cut off their body parts, and they truly believe that that's the right thing to do. So when those symptoms are really out there, that person really needs to be kept safe. They may stop eating, they may stop sleeping, they're not taking care of themselves normally, so we need them to become stabilized. So then, which leads us to that stabilization phase where the symptoms are getting better, they're going away, and we're trying to move that person towards a previous level of functioning. So usually in the hospital, we are going to use medications. If they're able to tolerate group therapy, we may try to do some group therapy, but we're going to try to keep stimulation on the lower side. We're not going to overstimulate them. We're not going to increase their stress and anxiety level by putting them in a high functioning type of group that they're not able to participate in. And we're going to try to help them just really to meet their very basic needs of cleanliness, good food, fluids, appropriate amounts of fluids, things like that, to kind of keep them physically and mentally more stable. Of course, one of the biggest things a nurse can do is provide education. Again, I think I mentioned this before, that back in the 80s, we never told a patient their diagnosis. And it just was unheard of to ever tell a patient, well, you have schizophrenia, and this is what schizophrenia entails, and this is what you should do to take care of it. But thank goodness we are different now, and we do talk to patients about their diagnosis, because if they don't know what their diagnosis entails, how are they going to take care of themselves? So the more education they have, the better. And also their family member needs to have education, because they also need to know how to support their family member and how not to support their family member. So in the maintenance phase, that becomes the person's like new baseline. So perhaps they're not going to get back to the same level of functioning that they had before the illness. So again, most of the time that my experience has definitely been that people have this as a chronic, lifelong illness, but it certainly can be maintained, and you can have control of those symptoms so that person can at least live, a decent life. So we have to see what is their new baseline. Unfortunately for some people, if they don't have really good symptom control, their baseline may be that they still hear voices. Perhaps they always hear voices, but when they're better, when they're at their baseline, whatever that new baseline is, perhaps the voices are lower, they're mumbling, they really can't listen, they can't hear very well what the voices are saying. And maybe they're just tolerable, and that person learns to deal with them. Versus when they're really ill and in more of the acute phase, then maybe the voices are screaming and they can't tolerate the voices, they can't sleep, they can't concentrate. They're suicidal because of the voices. So definitely bringing them down to residual symptoms, and a baseline would maybe be that the voices aren't gone completely, but perhaps now the voices are tolerable. So we do have to take a look at each of the symptoms the person has and what their baseline level functioning is, and as nurses try to support them as best we can. Of course, one of the biggest issues we face with people that have schizophrenia, well, I don't think people with schizophrenia don't have a monopoly on this issue, but we definitely see this a lot with patients that have this diagnosis, but that would be compliance. So we see compliance issues with people that have all kinds of other disorders too, substance abuse disorders, depression, sometimes anxiety disorders, bipolar. So there's lots of people with lots of different reasons why they are not compliant. But for the person that has schizophrenia, many times it's that they truly don't understand the need for medication, or it's possible that they have side effects that are really distressing to them, and they really don't like their side effects. They don't like how it makes them feel. Sometimes their sexual functioning is affected. Sometimes they can have enormous amounts of weight gain. There's a couple of the antipsychotic drugs that can cause 100-pound weight gain. Therefore, if somebody gains 100 pounds, you almost can't blame them for not wanting to take that medication any longer. So really doing a lot of teaching about adhering to treatment, keeping up with their doctor, taking their medications as prescribed, and perhaps even using some community-based resources for people that have schizophrenia. So let's look at some of the symptoms that we're going to see. Positive symptoms. So positive in this way does not mean good, okay? It just doesn't. Positive symptoms are the things that we look at that really set people apart from other people. So it's like something added on to your personality. So it's positive in that way, that it's something above and beyond, in addition to our usual personalities and ways of reacting to the world. But it is not good. So positive is not good in this instance. So alterations in reality testing. So again, delusions are false, fixed beliefs that you cannot talk that person out of, no matter how hard you try. You can't reason with them. You can't present reality to them and expect them just to say, oh yes, of course you're right. That's just not going to happen. They truly believe whatever it is real. And it makes it difficult when that delusion has to do with perhaps food. Maybe they think that hospital food is poison, and somebody is specifically putting poison in their food. You can't talk them out of it. They will not accept food from you. They will not accept food from the hospital. Maybe at best, people can bring food from the outside for them. Maybe they'll accept McDonald's food, but they won't accept hospital food because they think somebody in the hospital is trying to poison them. And you cannot talk them out of it. So they have alterations in speech and in their thinking. So they have an inability to think abstractly. So an example of the concrete thinking would be, I think your book gives this example too, but I've actually seen this happen where you ask a patient kind of an open-ended question, how did you come to the hospital? And you're meaning, well, like what circumstances, what brought you in for treatment? You're kind of thinking that way and expecting an insightful response. And maybe if you say, how did you come to the hospital? The patient's going to say, I rode my bike, I took a cab, my sister dropped me off. So they're answering it in a very concrete way rather than abstractly. So that can make communication with them very difficult. So the other interesting thing about concrete thinking is that it makes us very aware of how we communicate to people with schizophrenia. There might be some things that we could say that could be distressing to them, such as if you say, I'm going to take your blood pressure. They may think that you are actually going to take something out of their body, like you're taking their blood pressure away, and then maybe they're going to die because they won't have any blood pressure. So you have to think about the type of words that you use when you work with people with schizophrenia. So you could say, I'm going to check your blood pressure, but maybe not say, I'm going to take your blood pressure. So just implications on how we have to communicate with people that have schizophrenia. And just going back up to the alterations in speech, there are many different types of alterations in speech, and that can make communication very, very difficult. Some patients' thoughts are so disorganized, it is very difficult to really understand what they're trying to tell you. I know one patient that I had a long time ago would get the newspaper, and he would look at the comic strips, and he would find a comic strip that represented like how he felt that day. So he would come up and bring us nurses this comic strip and show it to us. And so we learned over time that he was trying to tell us how he was feeling, even though he wasn't able to express it verbally. So the other thing that people do with alterations in speech is that because their speech is so disorganized and it's so difficult to understand them sometimes, that we have to, as nurses, look for a theme in what they're talking about. So if you can pick out a theme, maybe you can't understand the individual words, so don't even try to, piece it all together and make it make sense. Look for a theme. Is the theme that they're lonely? Are they sad? Are they angry? Are they frustrated? Just kind of look for a feeling or a theme in what some of their words are, and then perhaps it'll be a little bit easier to help them and to meet their needs. So specific types of alterations in speech: associative looseness, or we sometimes just say loose associations. So that just means that you start out talking about something and it makes you think of something else, which makes you think of something else. So again, very hard to follow their train of thought. Word salad is the most extreme form. It's just a jumble of words that are absolutely meaningless to a listener. So it's almost like, I think it's called word salad because picture a big salad bowl and dump a bunch of words in it and just mix it all up with your salad tongs, and then that's what comes out of their mouth. It's just an absolute salad of different types of words that just have absolutely no connection, and we can't make any meaning from that at all. So again, if somebody's talking in word salad, try to listen for a theme. See if there's some kind of a consistent theme or a feeling that you can get from what they're saying. Clang associations, so words are chosen are based on sound, and many times they're rhyming sounds. On page 198 in your Varkarolis, it gives you some examples of word salad and clang association. And I have heard patients do that with the rhyming. So words are chosen based on sound rather than what the actual meaning is. So again, it's hard to follow what they're trying to tell you. Neologisms are really interesting because it's a made-up word. So they completely make up a word, and it only has meaning for them. They are the only ones that know what that word means. Again, going back to that video on Heather, the schizophrenia video that's in Blackboard. I believe there's a point in time where she has a word that is a made-up word. So I believe if you listen carefully, I know it's hard because of her speech is kind of garbled, but if you listen carefully, I think she has a neologism. And echolalia is a pathological repetition of somebody else's words. So if somebody says, so if you say to them, how are you today? They're just going to say, how are you today? They're just going to repeat back what you say. They're not going to answer the question. Other types of abnormal speech patterns, circumstantiality. So that basically is very, very unnecessary details. They just go on and on and on. You know, some people do this just ordinarily. Maybe you think I do this in some of the videos. I just kind of go on and on about something. But anyways, my husband has a really good way of talking about what circumstantiality is. It's you ask somebody what time it is, and they tell you how the watch was built. So they give you all this extraneous detail that is just absolutely unnecessary to like the question that you asked. Tangentiality is they go off topic. They don't ever reach the point. So they go off on a tangent and they start talking about something else. They never get back on track. Cognitive retardation just really is slowed thinking, and you can tell this because sometimes people have very slowed responses. Like you ask them a question, you expect them to respond right away, and they sit there and they stare, and they take quite a while. So this can be very, very pronounced in some patients, and they actually take quite a while before they will answer your question. Pressured speech, on the other hand, is just really urgent or intense speech, and you almost can't break into their conversation and stop them and ask them a question. It's just like it's got to come out of their mouth. Very similar to what happens when people are bipolar. So I think we talked maybe a little bit about pressured speech in bipolar. So it's that urge to just keep talking and talking and talking. Kind of think about a garden hose, and just if you put your finger over it, how you're trying to stop it, but it just keeps, it squirts out even harder. That's kind of how pressured speech is. Having a flight of ideas, moving rapidly from thought to thought, it makes it difficult to follow the conversation. Sometimes people use kind of symbolic speech. So the example they give in the book is, demons are sticking needles in me, which means he's experiencing pain. So he's using kind of the patients might use a symbolic way to express their thoughts or their feelings. So distortions of thought blocking. So that is very striking in people with schizophrenia. And again, sometimes all of us can do a little bit of thought blocking. So if you're talking and all of a sudden you kind of lose your space, you lose what you were going to say, and then you kind of are like, oh, what was I just talking about? So, that happens to everybody once in a while. But with somebody with schizophrenia, it's very, very pronounced. They can't finish their thoughts. They start talking about something, they block, and they just stop talking and stare into space. And even if you cue them and you say, hey, you were just telling me about, they can't pick up where they left off. They absolutely can't remember what they were talking about. Thought insertion means that they feel like somebody can insert thoughts, put thoughts right into their brain. And then the opposite of that would be thought deletion. So they think thoughts can be taken out of their brain by somebody else. Somebody else pulls thoughts right out of their brain. Magical thinking is a belief that their thoughts or actions affects others. And, this can happen also in children, but it is not a problem if it happens in children because it's just part of their normal development. But if you see this in an adult that has schizophrenia, that is definitely, definitely a symptom that we're looking for. So they give an example in your book about, like with children, if they think that wearing their pajamas inside out is going to make it snow. Well, in children, that's magical thinking. In an adult, that would definitely be a problem, right? So paranoia is basically that fear. It's very irrational. It can be very mild, or it could be that you think that somebody is actually going to kill you. So paranoia can actually put somebody at risk not only for self-harm, but actually more for harming others. So if you're paranoid and you're fearful and you think somebody is going to kill you, they're out to get you, you're going to get them first. So that actually increases their homicidal types of ideation and behavior. So that is something really that we have to take very seriously when we assess that paranoia, and keep that in the back of your mind. That might be a precipitator for violence. Case study audience response question. During the assessment, getting back to Eric, the college student, he has trouble staying on topic, zipping rapidly from one thought to the next, making it hard to follow what he's trying to say. So which speech disturbance is he exhibiting? Is it pressured speech, circumstantiality, flight of ideas, or tangentiality? So I'm hoping that you say flight of ideas, because that's going rapidly from one thought to the next. So the others are just a little bit different from that, but many times people that have schizophrenia, sometimes they can actually exhibit all of these different abnormalities of speech. Now we have alterations in perception. So we talked, I think, already a little bit about, in the anxiety disorders unit, about depersonalization and derealization. So I'm hoping you remember what those are. So depersonalization deals more with your own feelings of like that you're not real, and derealization is the environment around you. Hallucinations are sensory experiences, and the main types are auditory, visual, olfactory, gustatory, and tactile. So those have to do with our senses. Command hallucinations are part of auditory, but command hallucinations bear special thought, because again, people, if they have command hallucinations, people tend to do what the hallucination, the voice, is telling them to do. So an example, a patient came into the hospital a few years ago and said they were going through, when they were driving, they were going right through red lights, because the voice was telling them when they approached a red light, instead of stopping, the voice would say, go, go, go. So they ended up flooring it and zooming through a red light multiple times. So, and then thank goodness that person came to the hospital, because that was a little bit scary for them, that the voice was telling them to go through a red light. So the voice can tell people, voices can tell people to jump off a roof, can tell people to kill themselves, to throw their child down the stairs. Oh, there's an article I cut out a few years ago about a woman in San Francisco that threw her 3 children into the San Francisco Bay because the voices told her to. So we have to take command hallucinations very seriously, and that's something that we are going to assess every day when we're in clinical. If somebody has hallucinations, if they have voices, especially if they have auditory hallucinations, we want to make sure that they are not command hallucinations, because they're very hard to resist. People follow what the command tells them to do. So auditory is hearing things, and it can be very mild all the way to screaming, and then all the way to command hallucinations. Visual, seeing things that aren't really there. Olfactory, smelling things that aren't really there, and they're usually not very pleasant smells. Could be like things burning or rotting, so you're not smelling like popcorn or roses or something nice. Gustatory is taste, and again, my experience with seeing people that have gustatory hallucinations is that it is not something that is very pleasant. We had a patient a few years ago who felt like he was tasting feces in his mouth, so he was spitting everywhere because he just wanted to get that taste out of his mouth. And tactile is usually feeling something on you, like perhaps bugs crawling on you. We can also see tactile hallucinations in alcohol withdrawal. So when you're doing a CEWA, we always ask people if they're feeling like bugs are crawling or if they have like tingling on their skin, because that could also, it's possible that that could be also a symptom of withdrawal. So really in schizophrenia, the auditory and visual and command as part of that auditory are the most common types of hallucinations. If somebody's having olfactory, gustatory, or tactile hallucinations, we might suspect something else is going on, like we think about perhaps something organic going on with their brain. So perhaps some kind of brain injury or drug-induced. And again, tactile is really pretty closely associated with alcohol withdrawal. So we might want to be thinking of something else and doing a thorough assessment. Illusions are actually misperceptions of a real experience. So the example they give in the book is that a man sees a coat on a shadowy coat rack and believes it's a bear. It could be in the hospital if somebody sees maybe a string or something, or a cord attached to like a blind or something, like their blinds, they might think that cord is a snake. So there's something actually physically there, but they're just misperceiving as to what it is. And again, I've seen illusions more happening in alcohol withdrawal than I have in schizophrenia. So some alterations in behavior. So there's lots of different words that we're using here that are probably really different from what you're used to experiencing. So catatonia, or being catatonic. So people that have that symptom, they have an absolute decrease in the rate and amount of movement. So sometimes they are just absolutely motionless, and it can be for hours at a time. It can be for days at a time. So we really do have to think about how severe that is, and think about them as like a total care mental health patient, because they're not eating, they're not drinking, they're not, taking care of their bodies at all. They may need to be catheterized. If they get to the point where they're not eating and drinking for too long of a time period, they may even have to do other measures like being tube fed. But you would hope that they would be able to, through medication or possibly electroconvulsive therapy, to bring that person out of that state so that they're more cooperative. Very difficult to get them to take medications also when they're catatonic, because literally they are not moving at all. They are not responding to you. Many times they keep their eyes closed. They're mute, or sometimes they do that echolalia where they just repeat your words and they don't really answer your questions ever. So very, very difficult. So they can suffer from exhaustion, pneumonia, blood clotting, malnutrition, dehydration. So lots of physical comorbidities that go with being catatonic. So again, this person who's catatonic is like the ICU of mental health. So they really need a lot of comprehensive, good nursing care. People can have motor retardation, so that means just their movements are slowed. So they're moving slower than usual. They may spend a lot of time laying in bed, but they do get up and around, and they're, sometimes meeting at least some of their basic needs, although they may need help to get into the shower and things like that, but they're just really very slowed. Motor agitation is running, pacing. Lots of people with schizophrenia pace. I just see that all the time. They may respond to internal stimuli, so they may be responding to hallucinations, or they may be responding to things on the unit, external stimulation. So the agitation puts that person at risk, because again, they could be exhausted. If they're not in the hospital, they could be like walking into traffic. I have known people that have walked and paced so much on the outside before they've been to the hospital that they've worn through the soles on their shoes, and then they have terrible foot problems, blisters, chafing of their feet, loss of skin integrity, just from the amount of pacing that they can do. Let's see, what else do we have here? Stereotyped behaviors. So repetitive behaviors that don't have a logical purpose. So it could include things like, they could be going through the motions of like as if they were painting, but they don't have a paintbrush and they're not painting anything, but they may be just looking like they're painting something. So stereotypic behaviors can be really variable for different patients. Waxy flexibility is something that usually we see when somebody is catatonic. So that means that you can move their arm in a different position, like you can move their arm and put their arm like straight up over their head, and they will leave it there for hours. And then you move it back, and then they'll leave it there. So they allow you to change their body position, but they do it, but then they will keep it in that position for many hours sometimes. So when they have that symptom, it's almost like they're a statue. So echopraxia. So we talked about echolalia. So that's kind of repeating after somebody, like just if somebody says, "How are you today?" they answer, "How are you today?" Echopraxia is that they are mimicking your behavior. So whatever your behavior is, so if you're walking or if you use certain hand gestures, they're gonna actually imitate what you're doing. So negativism is a tendency to resist or oppose the request of others. So negativism gets played out. I've seen this when people are catatonic. So you're trying to get them to take their medication. So you're trying to put the pill up to their mouth and get them to take their medication, and they clench their jaw and they clench their teeth, and they will not, they tighten up their lips really tight so you can't possibly get that medication in their mouth. And the same thing with trying to get them to eat. We never would force feed somebody or force their mouth open to take the medication, but sometimes if a person doesn't have that negativity, you can put the medicine cup up to their mouth, and they'll open their mouth and you can put the medicine in, and then they'll take a sip of water, if you put the cup right up to their mouth. But if they're having that negativism, they're literally tightening up their lips, clenching their teeth. So they're basically behaviorally doing the exact opposite of what you want them to do. They have impaired impulse control, so they may throw things on the floor. They may do all kinds of behaviors that just aren't, showing self-restraint. They may have gesturing or posturing. So again, when you're posturing, it's very close to being catatonic. I've actually, I think, only seen this in people that are catatonic, where again, they take a pose and they can stay in that pose for hours. So it's again, kind of like being a statue. So very unusual grimacing of their face can also be present. They can have impaired boundaries, so it's kind of like they don't know where they end and another person begins. So they're going to be invading their personal space. They might grab something off of somebody else's meal tray and eat it or drink it because they just don't realize that it's not theirs. Negative symptoms. So the absence of essential human qualities. So negative is negative in this aspect, whereas, I know I'm confusing you, whereas positive is really not good at all. So really the positive symptoms are something is added to a normal person behavior. Negative symptom is something that is taken away, basically. So the absence of essential human qualities is a good way to look at it. So anhedonia means the absence of the ability to experience pleasure. I think we might have talked about this in depression, right? I hope that word rings a little bit of a bell. So the word hedonistic means like pleasure seeking. So people that are just excessively looking for pleasure, that's kind of where that word comes from. And anhedonia is the absence of pleasure. Nothing brings them joy. Nothing brings them pleasure. Nothing is fun anymore, even things they used to enjoy. So again, these negative symptoms are going to sound to you a lot like depression. And they are very closely related. That avolition, again, that lack of get up and go. So the ability to just get up, fix themselves a meal, take a shower, brush their teeth, get dressed for the day. It's not happening. Many times they might just be staying in bed and not attending to their ADLs, or just barely doing what's minimal, but perhaps not bathing or dressing appropriately, perhaps for long periods of time. I think the worst case I ever saw was the guy who came in the middle of March to the hospital, and he had not showered since Thanksgiving. Yep, so from November to March, he had not taken a shower. His hair was extremely matted and greasy. His beard was out of control and matted, and body odor was just unbelievable because that person had not showered for months. So asociality. So they really don't seek out social relationships. Again, there's a continuum. I have seen some patients with schizophrenia that actually do seem to relate pretty well to other people, that have relationships with others, even get married, have boyfriends, girlfriends, but just a basic lack of even wanting to be with others and to want to socialize, because that really you have to have, that ability to develop empathy and to be able to hear other people's feelings and thoughts and to kind of have that mutual back and forth that you need to have a social relationship with can be very difficult. And sometimes the anxiety of being around other people keeps them from being social. Sometimes they actually have a lack of being able to read other people's social cues. Therefore, they may not even pick up on other people's distress. They could walk right by somebody who's sitting in the hallway crying and not even notice them. So that lack of being able to read other social cues really does impair their ability to, to have a social relationship too. And sometimes they just don't want to be around other people. It's just too difficult for them. Affective blunting. So when we say somebody has a blunted affect, it means that they have less than normal facial expression. So you can't really always read them. They're not very expressive. They might have a little bit of a smile, but it's not going to be a full beaming smile like other people would have. So it's really a reduced ability for them to express their emotions. Sometimes we have a flat affect, and that means that they don't have any expression at all. You cannot read their face whatsoever. It's just completely flat, emotionless, and expressionless. Apathy is just that decreased interest in or attention to activities that otherwise would be interesting or important. So apathy, they just don't care one way or the other. Alogia is a reduction in speech, and sometimes we call it poverty of speech. So that can also contribute to their having poor social functioning, because when I think of alogia or poverty of speech, I think of the person that it's so hard to communicate with that you feel like you're pulling teeth trying to get them to say anything. And I know if some of you work with patients that have this disorder of schizophrenia in the clinical area, you're going to say to me, I just can't get them to talk. I'm getting one-word answers. Even when I say an open-ended question, I just get a one-word answer. That's poverty of speech. So a good example of that would be if you have a patient that you ask them a question like you're wanting to know about their family. So you say, do you have any children? Well, a person without schizophrenia is probably going to say, yep, I've got a boy and a girl. Their names are Christina and Robert. They're 5 and 6 years old, and they're the joy of my life. So you get all this information just from one question. But if somebody has poverty of speech or alogia, you're gonna say, how many children do you have? And they're gonna say 2. And you're gonna say, are they a boy or a girl? And maybe they'll say, one's a boy, one's a girl. And then you're going to say, well, what are their names? And then they tell you their names. And then you're going to say, well, how old are they? And then maybe they'll say how old they are. So you see what I'm saying? It's like it's pulling teeth. They don't just spontaneously give you lots of information that you're looking for. It's like pulling teeth to try to get them to say anything. So affect is that outward expression of a person's internal emotional state. So when we talk about the affect, we're kind of looking at their facial expression. So again, flat, no expression whatsoever. Blunted is less than normal, but still, at least you can tell if they're at least a little bit happy or a little bit sad. It's just not going to be a full expression. Inappropriate affect. So that is when their affect is sometimes completely the opposite of what you would expect. So they could be talking about something very, very sad and tragic, and then they're laughing when they're talking about it or smiling. So that is not appropriate, right? Our affect should match what we're talking about. Sometimes a person's affect is kind of what we would call bizarre, because we can't make sense of their facial expressions. It could be odd, again, illogical, inappropriate to the situation, and maybe they're having some grimacing and just some odd facial expressions. So I think cognitive symptoms, I'm going to start another recording, so I'm going to leave you for now and record again in a little bit.